afternoon, everyone. All the participants in this Iis Educational Fund Symposium, which is organized in collaboration with the Asha Foundation, Bangalore. And the theme is HIV science and community in South Asia, keeping HIV responses effective in pandemics. I thank you all for being connected from all over the world. I am Dr. Ishwar Gilada, currently Governing Council member of International AIDS Society, representing Asia and Pacific. I'm also President of AIDS Society of India, Governing Council member, and also the General Secretary of Organized Medicine Academic Guild, which is a conglomerate of 15 professional organizations of postgraduate medical doctors in India, and also founder and Secretary General of People's Health Organization, which is India's first organization which started HIV awareness way back in '85 and HIV clinic in '86. I currently practice HIV and infectious diseases at Unison Medicare and Research Center, which is a comprehensive HIV care clinic running since 1995. I would like to first discuss the main challenges and recent updates on HIV response in South Asia, in particular in the context of COVID-19 pandemics. And we have seen how this pandemic affected all of us. Not only that, there has been a lot of collateral damage which we are realizing day by day. For example, the facilities for HIV care, support, testing, PrEP and PEP, tuberculosis, they were all compromised during the COVID scenario. We'll have 4 sessions here and spread over 2 days. So there'll be 2 sessions on first day, 17th, and 2 sessions will be on the 18th. The first session is on lessons learned from COVID-19 for the HIV response. So lot of issues which are there, which are coming from the community, will be discussed. Science for action on advanced HIV and comorbidities will be discussed in second session. On the second day and the third session, it will be bringing the focus back on key populations in the HIV response, with a spotlight on people who inject drugs or injection drug users. And the last session will be on innovative prevention and treatment of both HIV and tuberculosis. Now, throughout these sessions, we'll be hearing from many important stakeholders, ranging from scientists, doctors, key community people, local community-based activists, and those who are important in HIV response. I hope participants in this meeting will gain a better understanding of HIV science and few findings, solutions to potential challenges they face at work, ideas on how the latest HIV findings can be applied to their local context, and strategies to improve HIV policy and programs. We also hope to participants will gain new contacts in the field of HIV. Though if it was a physical meeting, we could have been more easily able to find out contact. But even through this kind of scenario, you can meet some people, you can keep them in touch with them, and we can decide future collaborations. Over the last 2 years, we have seen 3 pandemics. One was a COVID pandemic, second was a pandemic of guidelines, so many guidelines changed, and third one was a pandemic of webinars. So we are all tired about webinars and we would like to meet physically. But because the guidelines of different states in the country and different countries were not certain, so we decided to have this as a virtual meeting. Before we start, I would like to thank the View Healthcare for their support, not only support, their generous support of this virtual meeting and for making it possible. Now, I would like to kindly invite Dr. Glory Alexander, who will be chairing this session, and I would like to introduce her. She is my colleague at the AIDS Society of India as Vice President. She has been Governing Council member of AIDS Society of India for last 10 years. She has been Director of the Asha Foundation in Bangalore, which was started way back in 1998. And I'm fortunate that I witnessed that opening ceremony along with the mega film star Sunil Dutt and one of the High Court justices in Bangalore. After working for a few years in Bangalore Baptist Hospital, she decided to start this foundation, and Asha Foundation is doing wonderful work in the field of HIV/AIDS. Dr. Glory has been recipient of so many awards. One of her recognition was from the Madras University, R.V. Rajamma Gold Medal for MD Medicine. She has also received Rajiv Gandhi Ekta Award, the International Ashoka Fellowship Award, the Double Helical National Award, the Karamveer Global Fellowship Award, and Dr. B.C. Rai Award, which is a very prestigious award in medical profession from the President of India in 2016. Dr. Glory has been also on the international scientific journals for the review committee for AIDS and behavior and PLOS One. Recently, she was appointed to serve the conference committee as a conference committee member of the International AIDS Society, and she is the only Indian on this committee. So we are proud of Glory and proud of Asha Foundation. Over to you, Glory. Carry on. Thank you.
Thank you, Dr. Gilada. Good afternoon, everybody. I am Dr. Glory Alexander, Director of the Asha Foundation, and I am pleased to welcome you all to this symposium. Asha Foundation is an organization working in the field of HIV and AIDS for the last 25 years and provides a range of services in this field. It's our privilege and honor to partner with the International AIDS Society Educational Fund to conduct this symposium. The International AIDS Society launched the Iis Educational Fund in 2016, and one of the purposes of this educational fund is to conduct small scientific symposia, which are held for doctors, other healthcare workers, social service providers, researchers, policymakers, and key community actors, thus providing access to the latest science and opportunities to question how that information impacts local epidemics. To build these meetings, the IAS partners closely with local academia, research institutions, and civil society organizations. So this is one such meeting. These meetings could not be held in the year 2020 and 2021 because of the COVID-19 pandemic. And this meeting is being now held in 2022 and is fully virtual. In the interim period of 2020 and 2021, COVID-19 pandemic occurred and displaced the HIV pandemic from the top position that the HIV infection held close to almost 40 years. The COVID-19 pandemic impacted the HIV response in many ways, and people working in the field tried to respond in their own way to this pandemic because many services in the field of HIV and AIDS were impacted. Therefore, I think it's very appropriate that this symposium is titled HIV Science and Community in South Asia, Keeping HIV Responses Effective in Pandemics. At this point, I would also like to thank the members of the Program Planning Committee for this symposium, Dr. Gilada, Taufik Bakali, Dr. Geetani Samarira, Daksha Patel, Leena Mengane, Dr. Sunil Solomon, and Divya Raj Joshi. Thank you for helping us put together a great program for this symposium. I am happy to moderate the session, and this first session is titled Lessons Learned from COVID-19, How to Deliver HIV Prevention, Testing, and Treatment Services in the Midst of a Pandemic. This session will aim to provide a regional overview of the lessons learned from the challenges and opportunities brought by the COVID-19 pandemic to HIV prevention, treatment, and care in South Asia. A specific focus will be placed on re-accelerating HIV testing and treatment and how to amplify innovative approaches developed by community actors in the face of the COVID-19 crisis. I am therefore looking forward to the many interesting presentations from our great lineup of speakers. After their presentations, the speakers will participate in a question and answer session, which I will be moderating. During this time, the audience will have opportunity to ask questions to our panelists by submitting them through the chat box. We sincerely hope that this program will be of value to you all for your current work, and that the key recommendations and discussions will help catalyze action, strengthen your capacity to continue engaging in the HIV response, support you to continue improving strategies, policies, and practices, whether these be at the community, national, or regional level. Before starting, I would like to share some housekeeping rules with you. All participants are currently muted. I invite all those connected virtually to please introduce yourselves by typing into the chat box that is right underneath the screen, and you will see that your message shows in the interactive box to the right of the screen. Please type your first name, your last name, the organization you work for, and the country that you are from. Let's use this opportunity to connect and get to know each other. If you're having technical issues and are unable to see the chat box, I would like to invite you to change internet browser and to select all cookies to be able to interact with the speakers when entering onto the platform. Please use the same chat box during the question and answer time that will take place right after the presentations. You're also welcome to send comments in the chat box. The International AIDS Society is also pleased to present a special offer regarding its membership. As an active participant of the Iis Educational Fund South Asia Symposium, you are eligible for this offer. If you buy a one-year membership, you will get an additional 6 months added to your membership for free. And if you buy a two-year membership, you will get an additional year added to your membership for free. Please contact memberservice@iessociety.org as indicated on the slide. I would now like to start the session, and I would introduce the first speaker, who is Mr. Taufik Bakali. He is the Regional Director for UNAIDS Asia and the Pacific. Mr. Bakali has over 25 years of experience in development cooperation in health and education, including over 20 years working on strategy and evidence-based programming on health and HIV at global, regional, and country levels. Since joining UNAIDS, Mr. Bakali spent 16 years working in Asia and the Pacific. Mr. Bakali will present on COVID-19 and HIV in South Asia, regional overview of challenges and success stories. Over to you, Mr. Bakali.
Hello, and welcome to this 2022 Iis Educational Fund Symposium for the South Asia region. My name is Taufik Bakali. I'm Regional Director for UNAIDS for Asia and the Pacific, and I have the pleasure to share with you some reflections on COVID-19 and HIV in South Asia, basically providing a regional overview of challenges and some success stories as we have observed them in this time of the COVID pandemic. My presentation will just go through the following sequence. I will present a little bit on some specifics of the HIV epidemic in the region. I will discuss the HIV and COVID-19 intersectionality. We will share some stories and some information about the COVID-19 impact on the HIV response as we have seen it in countries in this region. And then talk about some brightness in the dark, some notable breakthrough and some good success stories that have been demonstrated in this region. And we will conclude with some main takeaways. So basically, with around 3 million people living with HIV in South Asia, we have seen, as in several other parts of the world, that the impact of the HIV response is slowing down, despite a notable success in the past, particularly around the beginning of the millennium, where we have been seeing, particularly in this region, some considerable results in terms of reducing the number of new infections. However, in these recent years, we realized that these numbers, this trend has slowed down, and even that we have missed the 2020 targets when we were well on track to achieve it earlier, but then we missed it. And clearly we see that we are not going in the right direction to achieve the new global AIDS strategy targets for 2030, which is to reach 2019, particularly as the trend of reducing new infections as well as reducing AIDS-related deaths have slowed down. In the South Asia region, as you can see in the bottom side of the slide, we see a mixed picture as we see it everywhere and also globally. We have some great success stories in ability of reducing new infections and also some challenging situations where the epidemic is still raging very high with extremely elevated rates of increase of new infections at really worrying levels. The particularity that we see across the region is that this is an epidemic that is mostly affecting key populations and these partners. At almost around 94% of all infections are within key populations and their partners, sexual partners and clients. And this specific aspect is really important for us to consider as we are discussing the relationship and the intersectionality with COVID. So when we talk about key populations in this region, one thing that comes to mind is the level of inequalities and vulnerabilities that these populations face. We talk about female sex workers, we talk about men who have sex with men, we talk about transgender, we talk about people who inject drugs, also prisoners, and in majority of the countries in this region, these populations are criminalized. But that criminalization is only one element that adds up to many factors to create and exacerbate those inequalities with regard to access to service. Criminalization, of course, gender norms, stigma and discrimination, programmatic policies, and also design of service delivery, which can be exclusive and not designed in allowing access for the specificities of these populations, create and amplify those inequalities. And the result is, as we see in the right side, we keep seeing the majority of the key populations who determined most of the epidemic in our region not accessing the services as they should. So it is for this reason that the Global AIDS Strategy that has been adopted in 2021 has put reducing inequalities at the center of its own logic by putting people living with HIV and communities at risk to HIV at the center of the whole response. It was quickly realized in this, and the strategy is strongly amplifying that the ability to achieve the numerical targets of prevention, testing, treatment, and also reduction of new infections cannot take place without achieving the other enablers-related indicators and targets, which are called the 10-10-10. And that complementarity of the elements is centric towards reducing, identifying inequalities and reducing them. Because a program, whichever way it is designed, will not work if you do not remove what prevents populations from accessing it. And this is why reducing inequalities is really important at the center of the HIV response. And I'm highlighting this point because this is really central into the discussions around COVID-19. Speaking of which, COVID-19, we have a lot of stories, a lot of studies, lots of reports coming up in the past 2 years that are showing us the levels of the impact of COVID-19 that has happened on different populations, on different segments of the population, the different facets of this impact, whether it's social, economic, and of any kind, the impacts on health, the impact on personal development, but also the interaction with the other aspects of light, including governance, policies, and how all these elements do have an impact in either sustaining the epidemic or limiting the ability to control it. I could not find a better representation than this one that is shown here in this slide, as published in 2020, still in the early days of the pandemic. But we do see a very strong similarity between the two pandemics in terms of how they impact on people and in terms of how the different environmental and policy and programmatic and implementation factors that are being established can have an impact on the epidemic almost exactly in the same way, taking away the specificities of what this pandemic is and the routes of transmission and all these things. And the one thing that we know is that in both cases, these two pandemics, they exacerbate each other. HIV status among COVID-affected people creates an additional vulnerability. COVID also had additional vulnerability and additional exacerbated inequality, particularly faced by all populations who are vulnerable to HIV. And we have seen a lot of impact that is demonstrated and documented in various studies and surveys. PHIV have higher risk of COVID-19 morbidity and mortality. And in most cases, particularly in the beginning of the epidemic, when the world was going into lockdowns, AIDS-related services were forced to interrupt and close down completely. The health systems were completely diverted into responding to COVID wave. The pace of HIV testing and treatment rollouts and prevention service delivery and all these things, has slowed down. We have seen, for example, that as the lockdowns have continued in between the first and the third quarter of 2020, that the net rollout on treatment has continued to decrease. And then the second wave has had an additional impact. So all those waves of reduction of achievements have continued to decline as the different waves of COVID kept coming and the lockdowns being reinforced. We have done some analysis in our region, and we have seen that globally for all Asia and the Pacific, the achievements that this region has been achieving, particularly with regard to net increase on treatment, have been seriously affected, whereby in between 2019 to 20, the net gain was only 5% when we were about 14-15% in the previous years. We realized that a number of countries are seeing that the gap towards achieving the 1990 targets are widening instead of closing down. And that's really a source of worry because it is pushing us to consider serious impacts on the epidemic. And as you can see in this slide, several countries, almost in every country, we have seen a decline in net increase of treatment between 2019 and 2020. So here it's important to refer also to the situation that within all what we have observed, some important breakthroughs have been identified, where some solutions have been established, implemented, tried out, and different modalities of service delivery, which removes that dependence of people to go and seek and access services. The modalities of service delivery have changed. And that innovation that have been created at that time has not only demonstrated greater impact in reducing the negative effects of COVID on the HIV programs, but in demonstrating that in reality, these are solutions that were much needed to bring additional acceleration to the impact of service delivery, the impact of the HIV program or the HIV response on the epidemic, because these have potentials for greater impact as they tend to remove the inequalities and remove the barriers that create inequalities for populations. As we can see in this one, the rapid scale up of PrEP initiation and some modalities of service delivery, including self-testing and index testing, which is leading to high yield in terms of identification of people living with HIV, much higher than what the solutions that were in the past. Also, at the same time, we are seeing here some examples in India, and we have many more across the region, where initiatives like this, when rolled out, they tend to reach people, even at the time of COVID, who probably were not likely to access those services behind. So the innovation in service delivery has been probably forced and to take place. And the effect of COVID had created the opportunities for these innovations to take place and to be established. You see here in the slides how a very high HIV positivity has been identified through models of index testing, and also leading to an extremely high, very good linkage to treatment initiation. But also you can see that a change of multi-month of the approach for treatment provision with multi-month dispensing has been very quickly and very well associated to a major decline on treatment disruption, as we have seen here in the case of Andhra Pradesh, and this is just one example. But we have also stories where community organizations have managed to find solutions to deliver services in an integrated way to populations that combine distribution of PPE against COVID, to distribution of prevention and treatment drugs for people living with HIV, or distribution of condoms and of needles and syringes to people using drugs. But also, even we have seen stories where the inclusion of mental health support has also been included as part of the service provision package that has been led, designed, and implemented by communities, leading to extremely high results. Lastly, I would just like to highlight that all these reflections that have been summarized in this presentation had been summarized in the recent World AIDS Day report published in 2021, which put a greater focus on responding to pandemic. Responding to HIV and other pandemic response has 5 key pillars that are critical elements for any current and future pandemic response. And we have seen how this works, and the report is full of evidence on demonstrating all these effects. First one is community leadership for the response and community-based response. Equitable access to health products, which is really key. Access to health commodities is really important, whether it's for testing, for treatment, for vaccine, all these elements, and this needs to be supported by the relevant policies and relevant capacities. Supporting the frontline workers for service delivery, and here's frontline workers are, of course, health workers, but also community workers and all the support frontline for responding to the pandemic, including the security, including police, including law and order, and all these elements. Human rights at the center. That's a core element for designing a response to pandemics. And of course, we need to keep having excellent and good data systems that highlight the inequalities, how they are affecting people, and who is left behind, and who is facing which inequality in which way. These 5 elements are critical to be put in place if we ever want to have a response to HIV or any other pandemic. And these have been developed on the basis of great set of learnings from 40 years of the HIV response, but also great learnings that demonstrates that the solutions designed for the HIV response can also work for any pandemic. I will stop here, and I look forward to the discussion sessions. Thank you so much for your attention.
Thank you, Mr. Buckley, for this very interesting, informative, and enlightening presentation. It's nice to see that there is still light at the end of the tunnel. I am now pleased to introduce Dr. Jalpa Thakkar, who will be talking on HIV testing and treatment at home, best practices from the pandemic. Dr. Jalpa Thakkar is the Program Director for Project Accelerate in India. Over to you, Dr. Jalpa Thakkar.
Good morning, good afternoon, good evening, everyone. I would like to start with thanking the scientific and the organizing committee of the Iis conference for giving me and my organization the opportunity to present on the interventions on HIV self-testing in India. Globally, the HIV self-testing has proven to be a very successful strategy in reaching the high-risk population. India's National AIDS Control Program has successfully accelerated towards the UNAIDS 95 goals. However, 24% of the persons living with HIV in India are unaware of their status. This is further reflected in the fact that the new infections over the past decade have plateaued and not declined. The prevalence and the incidence in India also indicates that the epidemic is still very KP focused, but they are being reached primarily through the traditional services, which are limited to the physical sites. And still there are hurdles related to long waiting hours, distances covered, inconvenient timings, and stigma and confidentiality issues. In the past decade, India has also seen a very great increase in the internet penetration and the usage of online platforms for dating, for casual sex, for soliciting, and even for accessing health. There is therefore a very huge avenue for us to reach this high-risk online young and hidden population through a program such as HIV self-testing. So our objective from the program was to evaluate the impact of a web-based platform for providing HIV self-testing services on HIV diagnosis and linkage to care among the unreached population. The HIV self-testing platform was designed to operate at a very mass scale and be easily consumed by all the key population groups. The demand generation activities for bringing in more and more clients were tailored to reach the online high-risk individuals through different communication and marketing channels, such as one-to-one communication on dating apps such as Grindr, Planet Romeo, Blued, Facebook and Instagram-driven advertisements, and outreach to influencers well known and followed in the key population community. We also collaborated with a lot of local community-based organizations and influencer groups, especially in the high prevalence states of Maharashtra and in Telangana. Our HIV self-testing platform is 100% self-sufficient and is still supported by a group of virtual counselors and outreach workers for booking the orders, for pre and post-test counseling, and for screening with the HIV self-testing kit. The platform also facilitates linkages and referrals for treatment and prevention after completing the test by the testing kit. So we rolled out HIV self-testing in June 2021 in 7 states and simultaneously could expand to 28 states within just 4 months. And the platform was specifically designed for young and unreached population where one can order a test anywhere in India and it can be delivered through a courier service or through a pickup point. So now let me run you through this online platform and what the experience of the client is. The HIV self-testing online platform was designed to help the client book the kit and further complete the care cascade with or without assistance. So as soon as the client lands on the platform, either through an online advertisement or through the ORW, the platform registers every client with a unique ID as their mobile number to avoid any duplication. The client can then log in through an OTP with the registered mobile number each time they want to use the services. As a next step, the platform allows the client to fill in their basic social demographic details and assess the eligibility for ordering the kit. The eligibility on the platform is set as per the WHO guidelines. The flow then allows the client to choose the type of delivery. So either the client can go for a courier service which delivers the kit at their doorstep, or they can choose a pickup point from the nearest location where the client can collect the kit and even complete the testing at the pickup point as per their convenience. Further, as a 6th step, the client chooses if they need assistance while testing from the virtual counselors and can book an appointment for testing. If the client chooses an unassisted approach, they have access to information for users in local language, and there's a lot of audio-visual tools also available for client to look at how the test can be completed and the next steps after it. As the last step, the client gives the consent and the order is booked. The kits are delivered within 2 to 5 days for the client anywhere in India as per the details given. Based on the delivery or the pickup of the kit, the virtual counselors would then follow up with the client to complete the testing and to upload their test results for facilitating further linkages. As a next step, The ORWs or the counselors support the client to understand and interpret the results and further counsels on the need of confirmation based on the screening result. All the negatively screened clients are counseled and linked to the combination prevention methods such as pre-exposure prophylaxis and are advised for repeat testing after 3 to 6 months based on the risk factors. All the positively screened clients are counseled on getting a confirmatory test at a government center for free. And if the client wishes to go to a private sector, they are linked to the same and the client pays as per the fees of the private sector lab. For the clients who were screened positive after completing the confirmatory test, they were encouraged to upload the result and further book an appointment at a private or a government ART center for initiating treatment. Throughout this process, the clients are provided support from the virtual counselors for linkages and for timely initiation of treatment. The same Safe Zindagi platform also has the pre-exposure prophylaxis service delivery for those who are eligible and are interested in taking PrEP. So to present the results from this ongoing implementation study, we have used descriptive analysis to understand the reach of the program and the client level analysis. We have also analyzed the geographical, socio-demographic variables of the clients reached by the program, testing yield, linkages to treatment, and the risk level reported by the clients. The time frame used for the analysis was from June 30th, 2021 to February 15th, 2022. So the testing cascade looks as follows. After 8 months of implementation, the Safe Zindagi platform for HIV self-testing could reach 10,678 clients across 28 states and 168 districts in India. As you see in the cascade, out of those who were registered, 28% individuals opted to test with an HIV self-testing kit and placed the order successfully. And rest of the clients opted for other services that were available on Safe Zindagi platform, such as testing from a government center or a private center. Of the 2,976 clients who ordered the kit, 85% received the kit for testing. And of those who received the kit and completed the test, we achieved a very, very high report back rate of 92%. That is, out of 2,976, 2,329 individuals shared and uploaded their HIV self-testing results with the trained counselor. This reporting back of the self-testing result was much higher than what is seen globally, which is between 5 to 20%. And of these 2,329 individuals who completed and shared their test results, 5% of the individuals were screened positive, which means we saw a positivity of 5% in our program, also which is much higher than 0.2% seen in the national program. Further, out of those 124 were screened positive, 63% were linked to care, and 88% were also initiated on treatment. All the negatively screened clients were further counseled for PrEP and were initiated on PrEP as per their interest. We also looked at the age and the gender distribution of the clients who ordered it. So more than 70% of the clients were males, and amongst the clients who self-reported their typology, 79% were from the MSM community, 8% from the transgender community, 11% from the FSW community, and 2% from the people who inject drug community. And importantly, the program has reached a younger age group because 46% of the clients who ordered the kit were between 18 to 29 years of the age group, and the median age was 27 years. The platform also analyzed the risk factors associated with these clients. Of the clients who self-reported their risks, 54% were in the high-risk groups, 31% in medium, as compared to 11% who were in the low-risk groups. We also further analyzed the risk categories that were reported by the clients, and we saw that 73% of the clients reported not using condoms during a sexual encounter, 59% reported having multiple sexual partners, and some other associated risks were seen as sexually transmitted infections, injecting drug use, sex work, and non-consensual sex. We also further analyzed the care cascade for those who were screened positive, and we would like to highlight that the positivity was reported at 5%, which is much higher than seen in the national program. Hence, HIV self-testing is definitely helping us reach the right population in the hidden and the high-risk areas. And among those who were tested positive, again, 72% were males, and the median age was seen at 27 years. Amongst the other factors that were associated with the HIV self-testing clients, we analyzed the type of delivery, assistance, and acquisition, especially to see the positivity amongst these different groups. So we see that 43% who chose home delivery, 57% chose pickup points, and of those 5% positivity was seen in the home delivery category and 6% in the pickup point. 74% of the clients chose assistance compared to 27% who completed testing without any assistance from the counselors. And the positivity seen amongst the assisted testing was 6% as compared to 4% in the unassisted testing. As far as the gender is concerned, we see that the positivity amongst males was 4%, females was 3%, and transgender was as high as 7%. And now looking at the type of acquisition, we see that of the 2,976 clients who ordered the test kit, 46% were registered directly at the PUP or the pickup point. 42% were registered directly from the online advertisements or organic posts on the online platforms, and 12% were directly outreached by the virtual counselors through different dating apps. The positivity among those who were directly outreached was much higher than the average, and it was at 7%. Further highlighting the limitations in this particular program, I would like to mention that we still have scope to expand our risk assessment because more than 30% of the individuals who ordered the kit did not complete the risk assessment. There's also very limited data to still understand the drop-off between those who registered and those who actually ordered an HIV self-testing kit. And as you see in the data, there is still an opportunity for us to reach more and more high-risk women with these particular services. It makes it easier for them to complete the testing at their own convenience. And as we conclude, I would like to highlight that HIV self-testing is a very feasible, acceptable a method to reach the high-risk population. It has also reached the clients who are at risk and not actually being earlier reached by other traditional strategies. We also see that continued efforts to improve the linkage to confirmatory testing and initiation of ART is needed to overall improve the care continuum in the program and further reduce the newer infections in the country. I would thus like to acknowledge and thank all the members of the team of Accelerate Project at Johns Hopkins and at YRG Care. I would like to thank our funding agency, PEPFAR and USAID. I would like to also thank and acknowledge the continuous guidance and support received from NACO and from the State AIDS Control Society, and all the team members who worked at the forefront to continue this program with very, very successful results. Thank you very much.
Thank you, Dr. Thakkar, for this very interesting presentation and for giving us all the details about self-testing on an online platform. I found it extremely interesting and informative. I'm now pleased to introduce our next speaker, Mr. Manoj Pardesi, who's from the National Coalition of People Living with HIV in India. And he will present on innovative approaches to healthcare established by communities during COVID-19. Over to you, Mr. Manoj Pardesi.
Good afternoon, everyone. Thank you, Iis, for giving us this opportunity. My name is Manoj Pardesi. I am from Network of Maharashtra by People Living with HIV/AIDS and National Coalition of People Living with HIV/AIDS in India. So I'm taking this opportunity to present our work, especially in terms of COVID. And COVID has seen lots of phases, and we are talking especially our intervention with the community in the first and second lockdown. So in the first lockdown, where there was too much confusion about the infections, there is a huge fear. Nobody is like willing to meet each other, talk to each other. And in those scenarios, ensuring the access to uninterrupted ARV treatment was a big challenge. On the other hand, nobody knew, like because of complete lockdown, people are hesitant to come out. Those who having their routine refill, they were also not allowed to travel. Sometimes people are not able to disclose their status to the police people that why they are traveling. So there are lots of issues. And in those things, then we thought like how best we can ensure that ART adherence has been maintained and people can have access to uninterrupted ARV medicines. So I am presenting whatever small initiatives which we did. And so we have a community pharmacy, an integrated health center. It's called, the name is TAL Plus. TAL is T stands for treatment, A stands for adherence, A for advocacy, and literacy. So this TAL Plus is overall a platform of health and well-being to improve the survival and quality of life. Next, please. TAL Plus is started in 2006 initially when ART treatment was just started, and it was in the ration approach, because those CD4 below 200, those people are only eligible to access the ARV, and that is why this TAL Plus is started. TAL Plus is providing antiretroviral treatment at 40 to 70% discount with all peer-led interventions, peer-led support systems, and quality services. In 2014, from 39 clients, we reached to 3,500 clients, and every step we had some addition into the pharmacy. Initially, it was just pharmacy. Then it was a Life of Confidence Center, where we used to collaborate with the yoga, art of living yoga institutes, so that we can have a health and well-being approach. After that, in 2019, with the help of USAID, we converted TAL Plus into the Integrated Health Center and Community Pharmacy. And then this TAL Plus is having two models. One is Link Charity Center, and one is public model where subsidized ARV centers is there. Next slide, please. So I already mentioned that lots of it's a one-stop shop from prevention to testing to care and treatment support, uninterrupted treatment support. Next slide, please. So these are the services at TAL, and when we actually come to know that lots of people are facing problems, people are not knowing whom to contact. So we have started the helpline center, helpline service, and through our district level chapters, we circulated this number throughout the country. And the message was like any thing they required, clarity on COVID, any clarity on access to treatment, any support they need from this, they should contact on this number. And that is why we started this service at the first step. Initially, we used to get 10 to 20 calls in first week. But suddenly, once this number started floating around and people started getting services, the volume has to increase to 600 to 700 calls per day. And then we started the kind of pre-COVID questions, post-COVID support, and that time quarantine was the main strategy from the government. So during the quarantine, our doctor and peer counselor used to provide hand-holding support to the people, those who are needing the same. So later on, we also come to know that when vaccine started, and PLHIV group was one of the comorbidity to those who are eligible to get vaccine, but the uptake was very low. And the reason which we found is that people were hesitant to go and disclose their status into the public facility wherever they are having the COVID ART centers. So then NMP Plus, in collaboration with Pune Municipal Corporation and Maharashtra State Disease Control Society, we started the vaccine center within the TAL itself. And this is the country's first vaccine center for PLHIV and key population and their families, which is allotted to the clinic. Otherwise, the vaccine center was only allotted to the hospital setup. So this is one of our biggest achievements. Until now, we have vaccinated more than 3,000 PLHIV and key populations. Our both the doses are completed just 3 days before, last Friday. And now we are ready to equip for booster dose also. Next slide, please. So these are our some home quarantine supports which we as deal. Then we have along with that, we used to frequently do the forest screening. All those I explained, like these are the service packages which we used to provide during our home quarantine support. Doctor consultation, counseling, what nutrition they should eat, how should they get engaged. Whenever they feel depressed or something, like they can call our counselor. All these services were available. Next slide, please. So, as I mentioned, that treatment adherence for ARV and COVID-19 support. So, especially during the first time, this the course of whether it is azithromycin or calcium or supplements, when to take these tablets, when to avoid this, all those support we used to provide. Then in physical activity, there was a time slot for small exercise. Then nutrition guidance, special the why people are linked with us mainly is the mental health support, and that has been we provided during the crucial time when during first wave, confusion, fear was very high. Next slide, please. So along with that, I'm just explaining what are the other services at TAL Plus. So TAL Plus is also providing the HIV, hepatitis B and C, TB, HPV early detection, then prevention of PrEP, PEP. We also have self-testing and free male-female condom. Then we have the HIV treatment and hepatitis treatment, telemedicine. Especially this service has helped during lockdown a lot. Our courier and home delivery service has been increased by more than 50% after the lockdown. People now prefer doorstep delivery, and we also provide doorstep sample collections for routine diagnostics. Then apart from this, when we come to know that because of COVID also, CVD and other illnesses are coming up, and because of HIV related long-term illnesses, we also focused on NCD, STI, SRH, mental health and other OIs care and support treatments. So as 95 strategy, viral load suppression is our one of the key outcome indicators. Then now from this year, we would like to start this women's health as a in campaign mode, where we will provide this HPV screening for all eligible women, and then the increased uptake, demand generation activities with women living with HIV. We also, apart from the vaccine center, we also have the COVID-19 testing center, and then stigma-free vaccine center, as I already mentioned. Next, and all these services are highly subsidized. Just to give you one example, like, so if the ARV cost is say $100 in Indian rupees, it is somewhere around 4,000 rupees. That medicine we are giving it for 1,000 rupees. So if the $100 medicine, we are giving it for $30. So thank you so much, and I will be happy to take any questions on this. Thank you.
Thank you very much, Mr. Manoj Pardesi, for your very detailed presentation on the work that you and TAL are doing. Before we move on to the last speaker for this session, I would just like to remind the audience to please put in your questions into the chat box so that we can have the question answer session after the last speaker has finished. It's now my pleasure to introduce the last speaker, Pooja Kunwar Chetri, who is the focal person representing Nepal for Youth Lead, working as an activist to ensure access to treatment, care and support for young people living with HIV in Nepal, as well as at the regional level. She will present on COVID-19, young people and mental health. Over to you, Pooja Kunwar Chetri.
Namaste everybody. My name is Pooja Kumar Chetri and I'm from Nepal. I'm currently 25 years old. I'm working as a young activist in Nepal for the young people living with HIV, young drug user, and young sex worker. And I also represent young people organizations called YKP Lead Nepal. And today I'm here to talk about young people, mental health, young people in COVID, young people living with HIV. And to begin with, I'd like to say my content. Sorry. Okay. Today I'll be talking about people living with HIV and mental health, effect of COVID-19 on young people's mental health, and issues and challenges and priorities areas, and coping behavior. How we cope with mental health, and the issues and challenges. And I like to begin my presentation with data, some of facts and data. 10% of children and young people from age to 16 have clinically diagnosed with mental health problem. At 70% of children and adolescents who experience mental health problem have not had an appropriate intervention at early age. We tend to avoid mental problem. We focus on outer pain rather than the mental pain and mental illness. And also people living with HIV and AIDS are at higher risks of mental disorders. The stress is associated with HIV, serious illness or condition such as HIV can affect a person's mental health. It is important for people living with HIV to know they have higher chance of developing mood anxiety, cognitive disorder. For example, depression is one of the most common mental health condition faced by the young people living with HIV. And there are impact of COVID-19 on mental health and the quality of young people, young key populations, and young people living with HIV in Asia Pacific. If you can see the figure, there is clearly written that the mental health medication and psychological service are taken very less. If you see in light orange color, you can see many people are not able to access or are not going to haven't been to mental health medications or psychological counseling. And gray denotes that I need this but never had gone for it. And the effect of mental health on young people according to WHO, the breakdowns according to the profession, 6 psychologists for one. There are only 1 lakh. Sorry, there is 6 psychologists for 1 lakh population GI in Nepal, and no social workers and occupational therapists are there, especially in government hospitals. In Nepal, people with existing mental health and psychological disorder were more vulnerable to acquire COVID-19, but not everybody has access to mental health services. And and there are lots of issues and challenges like addressing the HIV epidemic in Nepal requires immediate actions and long-term continuity and sustainability. Also, stigma affects not only the number of seeking behaviors, but also the number of resources available for the proper treatment. Stigma and misinformations can feel overwhelming sometimes, and here are few powerful things that can help young people to deal with their mental health during COVID. And like swaying individuals' respects and acceptance remove significant barrier to successfully cope with their illness. Having people seeing you as an individual makes a very big difference, and that also can make that also can help you or help who is struggling with a mental disorder. And we can also advocate within a circle circle in our within the community circles. It helps to ensure the individual have same issues and opportunity as others uh, members in your community. And learning more about mental health also allows us to help and support to those who are affected in our community. And scale upping the advocacy, behavioral change activities, and mental health promotion intervention for the young people are very necessary. And implementing strengthening behavior surveillance to enhance and understand HIV, sexual behaviors, and health-seeking behavior is very important. And as we talk about mental health, it is very important that one should know that as your physical health is important, mental health is important as equal, and we give more priority to the physical health rather than the mental health. To be strong physically, you need to be strong mentally also. So by saying this, I like to thank you all for this very big opportunities, and thank you all for listening. I hope you guys will have wonderful time. Thank you.
So thank you so much, Pooja Kunwar Chetri, for your talk on the effect that COVID-19 has had on youngsters in the key populations. We now have the open discussion where question and answers session. All the speakers are on board, and we will go ahead with answering the questions that have now been raised in the chat box. The first question is, don't you think that the people who are infected with HIV can't come out and live properly without huge mental stress because of the Asian culture and laws? Who would like to take this question? Taufik Bakali?
Yes, happy to take that. A very interesting and very pertinent question, but the answer is multidimensional. In ideal world, we would get rid of all kinds and all forms of stigma and discrimination, which particularly impact on people living with HIV. Now, stigma and discrimination is an attitudinal problem, which translates in so many forms. The policies and the laws are one of them, but there are also cultural norms. There are also stigma and discrimination in different kinds of settings that impact on the attitudes towards people living with HIV. But also there is self-stigma. And addressing all these components does not mean that we can consider on resolving the issue of stigma and discrimination in one area. It has to be a comprehensive approach in resolving stigma and discrimination in all kinds of settings. There are 6 settings that are normally being discussed as part of the global partnership in reducing and eliminating all forms of stigma and discrimination. The most evident and priority ones of them are, I can list all of them. So first one is in the community settings. Then most importantly is healthcare settings, which is with regard to access to healthcare services. Then we have the workplace, we have the justice system, we have the education system, but also we have humanitarian settings with all the crises that happen around the world, which undermine the law and order and the ability to seek justice. So while we work on all these settings, there is also a need of empowering people living with HIV to overcome all the feelings of self-stigma. But this is a multi-dimensional approach that needs to be done. It's easy to say, yes, they can, yes, they should, but to make it happen requires a lot of effort that needs to be led by the communities, by the populations who are concerned, but also working on it in close partnership with all stakeholders that are very determinant on all these 6 settings that I have just mentioned. Over to you, Dr. Glory.
Thank you, Mr. Buckley. The second question is, how are the virtual counselors trained? I think Dr. Jalpa Thakkar, you can answer this question. How are the virtual counselors trained?
Sure. Sure. Thank you for this very important question. So the virtual counselors have been trained over the entire continuum of care cascade. First of all, the basics of HIV, right from testing, prevention to treatment. And most importantly, they have undergone professional training from the experts, in the team, from the national program, from the team from USAID, from Johns Hopkins, from YRG Care, from all our partner organizations. All the experts have trained the virtual counselors over a period of time, not just once, but every 6 months they undergo training on how to have counseling sessions with the people from the community, from not being from the community, how to counsel them on prevention and testing services, and after testing, how to counsel them for linkages and referrals. So it's not just ending at testing, but very important is to initiate treatment for those who are screen positive at the soonest possible. Only then we can break the chain of infection. So they undergo training from the experts in the program, and we also continuously give them, a field exposure, because we have some field sites in Maharashtra and Telangana. So they're sent to the field also to see actually on how the people are referred from, testing centers to the treatment centers in the physical sites. Apart from that, we also developed a lot of audio-visual, videos for the counselors to keep repeating it over and over again on how to, basically the key points over counseling for prevention, for testing, and for treatment. And apart from that, there are, monthly and fortnightly meetings with the counselors to understand, to troubleshoot any areas of counseling that they may need help with. So these are the various ways that the counselors are kept completely up to date with the program.
Thank you so much, Jalpa Thakkar. This question is also for you. Is there a way to assess what is happening with the people who receive a test kit but have not uploaded a result? Are they facing any psychological adversity, gender-based violence, etc.?
Yeah, thank you so much, and a very pertinent question. So, like we must have seen in the graph that we have over 92% of the people have actually shared their results with us. So a very minimal of 8% only have not shared. Also, we at some point in time have reached 99 to 100% also, but this is an ongoing process. So it takes about 15 to 20 days to slowly convince the individual and counsel them to complete the test and then to share their results. However, for those who do not agree to finally share, they sometimes respond. So our counselors are always in touch with the clients because they have inputted their mobile numbers, right, to log in, and those mobile numbers have to be valid, otherwise they won't get OTPs. So they're always in communication with the clients, and they try to understand what are the reasons. Most of the clients are not interested in completing the test once they order the test kit. That's one of the reasons. Second reason of the client could be that they would like to go and actually verify their test with a private physician or at any other center. Apart from this, one-to-one communication between the counselor and the individual who seeks care, we also have a feedback mechanism inbuilt in the system on the platform. So as soon as the client registers on the platform and they give their consent to order a kit and to complete the test, they also give the consent to complete a survey.
And an online survey feedback, it's a feedback survey, is sent to the client to understand what could be the possible reasons at various stages of the cascade, not just from ordering the kit to completing the testing. So these are the way. We have not yet encountered any such case where we have seen any cases of any mental disturbances or any case of violence or anything like that. But we do have mechanism in place to take feedback from the client anonymously also.
Thank you. The next question is for Mr. Buckley. Has there been a negative impact of COVID vaccinations on persons living with HIV since they have a higher risk of COVID-19?
It's a pertinent question, and there are some studies that have looked specifically at those questions. The recommendation that is coming up is that the vaccine does not have a negative impact on people living with HIV in any aspect of life directly related to HIV infection. The recommendation is that people living with HIV should have equal access to vaccines with the relevant considerations for their own health and the specificity. Now, sometimes HIV is connected or associated with a number of other comorbidities that may create some situations that require additional attention, particularly with regard to the provision or the access to vaccine. And these are all delineated and clarified within the vaccine types of guidance related. It's not the HIV infection, but it could be some other related comorbidities and effects. And there are a number of evidences that demonstrate or even recommend the need for people living with HIV to access COVID-related vaccine because of the additional protective factor that it brings to their health.
Thank you, Mr. Buckley. I would just like to add, if I may, a sentence that, none of the vaccines that are provided for COVID-19 are live attenuated. So it's really safe to give it to people who are HIV positive. I remember that during the earlier days, there was lots of concern about what vaccinations could be given to people who are HIV positive. And there was always concern about live attenuated vaccines, but none of the COVID vaccines presently available are live attenuated. Sorry for that interruption. The next question is for Manoj Pardesi. He wants to know whether the differentiated service model of HIV care has been initiated in all states of India, and any place where some best practices are documented. Are there any DSD models in India, which is a client-managed group model, where clients receive their ART refills in a network run by PLHIVs themselves? Any DSD model in India where ART refill visits have been separated from clinical consultations?
Very good question, doctor. Yes, doctor. Are you able to hear me?
Yes.
Okay. So, very good question. And in first and second lockdown, the entire HIV program is able to ensure 95% adherence is because of DSD model, differentiated service delivery model. There are 4 types of model we implemented that time. One is the people are coming to the nearest district level network. That is one model. SACS and ART center, we used to give the like certain number of medicines based on the caseload. Somewhere it is 100 bottles, somewhere it is 50, somewhere it is 20, somewhere it is 10. And this letter has been issued by NACO authority. So the implementation was very fast. Second thing, the other model is our outreach worker carries the medicine of the people based on the caseload that person is handling. And then people are either coming and collecting them, those who don't have a vehicle and things, the OW going and giving to them. That is another model. The third model was the buddy system model. So 4 or 5 clients are staying in one area. So one person used to carry that medicine, and then people used to access the medicine from that person. The fourth model was, and especially this model worked in both the lockdown, first and second, is by the government post home delivery. So areas where like very hard, in especially Himachal and Northeast, where in far-flung village only one client is there, and the government post has been, it took time. I agree, it took more than 15 days time, but medicine has reached to the person's home. So these are the 4 differentiated service delivery model we done. Based on this only, the TAL Link ART Center has emerged. And I am happy to tell that nationally the uptake of ART Center, Link ART Center is less than 50 clients. But the TAL Link ART Center uptake is almost 1,000 in 1 year. And it's a completely country's first peer-led Link ART Center. And the result is we have almost 1,000 clients. We have to stop new registration because we can't take more than that. Thank you.
Thank you, Manoj. The next question is to Pooja. How common are the psychological problems among PL-HIV in COVID era when compared to the pre-COVID era? Is it systematically assessed? Pooja? Okay. The next question is also for Pooja. Pooja Kunwar, are you there? Okay. I'm sorry,
Dr.
she's not
Glory.
Available.
Dr.
Yes.
Glory, this is Taufik here, and if I may just come back on this earlier question.
Yes.
About the mental health aspect.
Sure.
Which is a very pertinent question, and I think if Pooja was with us, she would have shared information about the work of Youth Lead, where they have documented the rising levels of mental health issues, particularly affecting young people. We all know this, the lockdowns and the continued repetitive waves of COVID and all the impacts, all kinds of impacts, including the economic, including access to work, including loss of jobs, all these have a serious toll on mental health. There are both combined different types of evidence. Some is coming from live stories documented through qualitative studies, which the Youth Lead have implemented, and we were pleased to collaborate with them on this. But also there are some studies. I just do not have an easy reference for this. But what I'd like to mention, particularly in the work of Youth Lead, and I mentioned this in my presentation without knowing that Pooja would be part of this panel, is that Youth Lead has designed an emergency fund to respond to the needs of young people, particularly, and they combine in their approach aspects of service delivery related to access to PPE, personal protection against COVID, with mental health services, with HIV prevention services to the people that they have reached. So the evidence linked to the action is a really good element that needs to be highlighted as the great work of Youth Lead. I just want to share this information as I'm exposed to it from my end.
Thank you so much, Mr. Buckley, for taking that question and responding to it. The next question is for Dr. Jalpa Thakkar. The self-tests are for a population which has access to such services. What about those populations that are not techno-savvy or are illiterate? Do you have anything for them?
Sure. Thank you very much for that question. I wanted to highlight that as well, but because of the limitation in the time, I could not in the presentation. So yes, so what we have done is for those who do not want to use the mobile phones to actually go online and book a test. What we do is we have something called as pickup points, and we have collaborated with the very local organizations, community-based organizations, a group of influencers, some NGOs also in certain districts of Maharashtra and Telangana to begin with, and slowly we are expanding in others like Karnataka also, wherein what they do is that we have a trained a point person at that particular pickup point who will go and do the outreach to those who are not really accessing services through the National Health Program. And they will, on behalf of that person, they will order a test kit. Oh, we just need a mobile number because we don't need a smartphone for that because it's just an OTP. And based on that mobile number, that particular point person at the PUP will do the registration, order the kit, help them complete the testing at that point itself because the kits are available at the pickup point also, and help them upload the test result and further complete the linkage. So in fact, it's very easy at the pickup point because there and there the test can be completed, the counseling, post-test counseling can be completed, and the linkages can be initiated. So this is the mechanism for those who do not have a smartphone or do not wish to log in and order a test kit by themselves. And the same way, virtually also, if there are some people who know or who have seen an advertisement somewhere or who have heard from their friends, we have a helpline number on our platform. And through that helpline number, they can talk to our virtual counselors. The virtual counselors can do the exact same thing that I just explained and can register, order, and upload the result on behalf of the client. But the entire process of consent, etc., happens as it is because the mobile number is that of the client. Thank you.
Thank you. This is a question for Mr. Buckley. This is related to the first question we answer about huge stress because of community. Same-sex marriages are considered as sins and against the law. If someone have many contacts with same-gender people, how can they overcome and say their story? It will just be hidden and it will spread this, isn't it? It's a comment, question. Would you like to take that, Mr. Buckley, or any of the other speakers on the panel?
I think it's a comment, and it is goes into the ongoing debates around criminalization of same-sex relations. And, it's just going along with that debate and the existing points of view. Now, the overall position is that it should not, we remain against criminalization because criminalization does not help. It even pushes people forward in hiding and prevent them and creates additional vulnerabilities and inequities in terms of being able to live a full life and accessing services. And that's the main point here. And unless there is a specific question, then probably we can see also the right profiles who can respond to that question. Over to you.
Okay, thank you. That actually brings us to the end of the question answer session. And just coming back to the topic, lessons learned from COVID-19, how to deliver HIV prevention, testing, and treatment services in the midst of a pandemic. I think this session was a very enlightening one. Mr. Buckley spoke about the impact of COVID-19 on people in living with HIV and how the effect that it had was similar in all spheres of life to that which happened when the HIV pandemic was first detected. We received information on self-testing services and how that service has been able to help in increasing the HIV testing among different populations. We've learned about TAL and the integrated services which are being led by peers and which are led by the key populations and how it is doing so well across the country. And we have also heard about how COVID-19 has affected the mental health of young members of the key population and how this has been responded to. Still, at the end of the day, one of the biggest challenges facing all of us in the HIV field is reducing inequalities And this remains the mainstay of handling the HIV pandemic and how we can reduce it so that we can overcome the challenges faced by the key populations and have a successful story to tell regarding the handling of the HIV pandemic. I want to thank all the speakers for their sessions and for all that they have done and for their contribution and participation, especially during the special and very busy time of the year. On behalf of Asha Foundation, we would also like to thank all the participants, and we hope that this session has been helpful and interesting to all of you. We hope that this information shared and discussed will help you reflect on a personal and professional level and on the lessons learned during the COVID-19 pandemic for the HIV response. We would also like to thank all the participants who sent questions during the discussions. And we also encourage you to share the recordings with your colleagues who were not able to participate with us live today. These will be available soon on the Iis Educational Fund virtual platform, free of charge, and they can join the platform anytime to watch the replays, which will be available next week. We are also pleased to announce that we will be hosting a short virtual networking event tomorrow at 6:45 p.m. Indian Standard Time, right after the last session of the symposium. This session will be held on Zoom, and you will be able to network with some of the symposium speakers and panelists, providing an opportunity for you to ask additional questions in a more informal setting. The registration link has been shared in the chat box, so please register if you're interested in joining. Thank you all. We hope to see you in 30 minutes for the second session of this symposium, which will start at 5 p.m. The session will focus on science for action, on advanced HIV and comorbidities in South Asia. Please connect using the link for session 2 from the home page of the virtual platform, just as you've connected for this session, or by clicking the link, which will be available on this page after the session is over. We will all see you very shortly. Please also remember to participate in the evaluation survey at the end of this meeting for the overall symposium. All participants will receive an email on Monday requesting that you fill in a survey to evaluate the symposium. We would greatly appreciate your feedback, which will help us to continually improve our symposiums in the future. You can also write to the Iis Educational Fund team anytime at iasedu@iissociety.org. Thank you and have a great mini break until the next session. Take care.